of them cleft lip and palate, some of them traumatic, some of them congenital. And before the surgery, and he is an amazing surgeon, he almost does exactly what Fahd does in the aesthetic context, simulating the operation that he wants to achieve on the soft tissue by injecting with local anesthesia and adrenaline. And he is, very comfortable with that, and the tissue handled that very well. So I think that's a very good tip. But I must warn everybody that when you are injecting in this very confined space, and we started with the nose, we are not going from more simpler to more complex, and you cannot, by following the principles or the experience, avoid complication. Complication is not the same as mistake or negligence. Complications can happen within the best practice in relation to following guidelines and working to the best of your ability to follow the evidence. Complication can still happen, and the catastrophic complication here is, the necrosis of parts of the nose, which unfortunately the literature has shown a lot of it. So from that, can I ask first if anybody has questions to any of the panelists here in relation of working around the nose? Yeah.
Hello. My question is for Dr. Fahd, please. I want to ask how much time we need between the initial injection of epinephrine and lidocaine and the other injection for optimum results, please.
It is said 8 minutes. It is said 8 minutes. But for example, when we do an abdominoplasty and there is a big scar that we follow, so we are injecting like 35 or 40 centimeters of skin, of future scar. So I have been, injecting and looking at the timer and opening. Within maximum 2 minutes, there is vasoconstriction. But for your safety, say 8 minutes.
My question is, when we injected epinephrine and lidocaine, the first injection, to see the shape.
Okay, to see the
How much time would
it's
we
immediate,
need to...
Immediately.
Immediately.
Because if you wait, it will disappear.
Okay, thank you. That's my question.
Yeah.
Thank you.
May I add a little comment? Donald Lalonde, he is a very famous plastic surgeon in Canada who advocated the use of adrenaline around hand surgery. And he is very kind of daring surgeon, and he has on YouTube a video where he is injecting his finger with adrenaline to show that it's safe to have vasoconstriction even in the fingers, and there is no risk associated with that. Now I must also say that I doubted initially this technique because I wanted to see the topography. If I am augmenting something and kind of putting a fluid there is going to camouflage that defect. And I was always worried that I will no longer know how to inject. And even this impressive coloration of Fahd, and it was not comfortable for me because I really want a tactile feedback. I want to feel and follow topography. But it is amazing how we can develop this even with the fluid. So persevering with that, I can then start to appreciate how the fluid is not actually similar to the local tissue, which when you have a defect there. So you should not have that in the back of your mind, that if you inject fluid, it means you lost the topography, you no longer are able to inject where you needed to inject. So you can develop that sensitivity, and you can easily displace fluid, but you cannot displace fat or subcutaneous tissue or a mass in the same way.
I would like to make a comment. When I started my training in plastic surgery, the question, and it's in the book of Dr. Sheen, there is almost an entire page where he is giving the argument for injection with adrenaline and lidocaine, although in these kind of surgeries they are done most of the time under general anesthesia. And today, no. So I'm deferring this to the expertise of Mr. Nasser. When did happen the switch for no surgeons to go? For injection with adrenaline.
It's nothing new. When I started training rhinoplasty about 30 odd years ago, my teacher and mentor, Tony Bull, always used 1 in 80,000 adrenaline, and he had no problems. His anaesthetist, in fact, would inject the nose for him before local anesthetic, before the general anesthetic. There are two different things. A general anesthetic gives general anesthesia, and they may drop the blood pressure for you. But giving a local anesthetic gives you, first of all, more vasoconstriction, as you quite rightly point out. Secondly, it gives you those tissue plates. And if you get under the subsmass area, all the vessels lie just between the smass and the deep tissue. And if you are underneath the smass, when you're doing an open rhinoplasty, you see the vessels. If you're clean below the smass, you've got no problems with this. You can pick them off. And if you, as you say, if you pinch the skin up and inject underneath, there shouldn't be a problem. But sorry, waiting, I would wait 15 minutes for the effective use.
Because it's surgery, it's not just hyaluronic acid.
In fact, how many minutes you have to wait is actually now experimental evidence. It's no longer guessing, and it's exactly 16 minutes. So until maximum vasoconstriction. Again, Don Lalonde has done this experiment. Now, I just want to ask Fahad, because like you use adrenaline and many don't, how long do you keep these patients? Like to know that this is not vasoconstriction or tissue ischemia, because this is the time, if you have a complication and a threatened area, to flood everything with hyaluronidase. So how you feel safe to send the patients home?
I kept only 2 patients. The one I showed you and another one, both of them were secondary rhinoplasties. So because in all the other patients, they are completely whitish, but I know, I have the certainty that it is epinephrine. I'm sure there are many dentists here, or some of them, they all inject lidocaine with epinephrine. So I would keep a patient if it's a secondary nose, if I am injecting in an extremely tight area, fibrotic, mostly in the lower 2/3 of the nose.
I think I will go a little bit farther and recommend to you all to not inject people who are going to catch a plane, the following day, or people who are going to leave on a train to another city. I would recommend to you all, maybe in the first 150 noses, to only inject people who are able to reach to you in half an hour. Or something like that, and you must give them your telephone number for the evening if they develop any complication, if you have not seen the whole area pink and red again. So if you send them with a little bit of vasoconstriction, please be generous, give them your telephone number, allow them to call you. Any problem, you have to act and act fast.
I would add to that the evidence at the moment says that in the patients that did have a lot of complications, it was 4 hours and 48 hours. So they need to be able to access you, and they need to be watchful in the first 4 hours, and you can truly sleep after 48 hours.
One question here.
Thank you. Actually, when we said that we are using deep fillers for this rhinoplasty. Now we know that it attracts fluid thereafter, water. So, same as you said, the question is, how do we know whether they will have skin necrosis following the filler because of the bloating of the filler, attraction of water? Thank you.
So the question was, would the hydrophilic properties of fillers have an implication on later on the filler expanding inside and threatening the kind of supply of the tissue?
No, at all.
Maybe if you, Dr.
You want, yeah, because you are talking about a hydrophilic effect of the filler in relation to the
Things it's called.
no, in relation to the infiltration, to the liquid of infiltration.
No, when you inject the filler,
Yes.
it can attract the fluids,
Yes,
water,
and then-
it can compress
Yes.
some blood vessels, and then apply pressure to the tissues so that you can have a necrotic area patch.
If it doesn't happen within the 4 hours